Because Metastar is providing CME credit for this presentation, we need to inform you that no commercial support has been received for this learning activity. No one in control of content has any conflicts of interest. And to earn CME credit or certificate of participation, you need to read the introductory CE information, view the webinar, and complete the evaluation, which can be found on the Fox Valley Advanced Care Planning Partnership website. CME is available for this webinar until July 15th, 2021. Hello, and welcome to Palliative Care for All, one systems journey to make generalist palliative care a reality. I'm Ellen Koski, and I'm the director of the Fox Valley Advanced Care Planning Partnership. Building upon years of work in the Fox Valley, the Fox Valley Advanced Care Planning Partnership was founded in 2016 and is supported by Ascension Northeast Wisconsin, Mosaic Family Health, and Theta Care, and it engages the entire Fox Valley community to make advanced care planning and conversations an integral part of living. What we are doing is normalizing advanced care planning for all members of our community. We are supporting advanced care planning education and action with our local healthcare providers and also within work sites and faith communities and educational institutions through consistent messaging about the importance and need for advanced care planning, along with tools and support for completing documents that are valid and useful when needed. We are working to change culture in the Fox Valley and to ensure the last chapter of life is the best it can be for each individual person. Part of our work is healthcare provider education, which is why you are here. Another part is metrics and data. Since 2018, we have conducted 2 iterations of a survey of healthcare providers in the Fox Valley, and I'd like to share a little bit about some highlights with you right now. So the survey was conducted in 2018 and 2020, and as you can see here, our sample sizes have been relatively small, but growing. So I encourage you to help us out with this and complete the survey when it comes out again in 2022. Between 2018 and 2020, we consistently found that 9 out of 10 respondents were comfortable having advanced care planning conversations with patients. We also found that 8 out of 10 said that they were comfortable communicating prognosis to patients. Now we're going to take a look at some questions that we asked about knowledge versus practice. So you can see here in 2018, we asked providers, when should advanced care planning be discussed with patients with serious illness? And about 70% indicated that advanced care planning should be discussed at a diagnosis of disease or beforehand. When we take a look at the data from 2020 here in orange, we now see that 80% of providers think that advanced care planning should begin at disease onset or before. This is a win, and we see this as an increase in knowledge regarding advanced care planning and the need to start advanced care planning early and to revisit it often, especially with patients with serious illness. Now we're going to look at the data regarding practice. So we asked providers, when is advanced care planning actually being discussed? I have both years of data indicated here because between 2018, the data actually stayed about the same. And what it tells us is that while our providers know that advanced care planning should be happening upstream, it's actually happening way too late. So here we see that about 80% of providers report that advanced care planning is generally discussed when a patient is in the last 2 years of their life. Similarly, when we look at when palliative care should be discussed, we're seeing that 90% say that it should be happening before the last year of life. Similar to advanced care planning, in 2020, we see a shift slightly upstream with this information. So again, this is progress where we're seeing knowledge increasing about palliative care and the need to discuss it earlier and more often, and so it can evolve and adapt with patient situation. As with advanced care planning, we see similar trends regarding action or practice versus our knowledge of when palliative care should be discussed. 80% say that palliative care discussions are occurring within the last year of life. This is way too late. So now I ask you, where do we go from here? How do we turn this knowledge into action? I want to add a piece about a question that we added for 2020 around at what age should an advanced directive document be completed? 90% of respondents stated that advanced directive documents should be completed before a patient turns 60. And actually the majority are saying it should be happening in a person's 40s or younger. We also know from the survey that 70% of providers felt that the conversation should be started by the primary care provider. When do you tend to bring this conversation up with your patients? When do you think these documents should be completed? And how is the current system set up to support this or hinder it? Finally, I want to leave you with this slide. So between 2018 and 2020, we had about the same number of providers respond of how many of them have their own advanced directive completed. So about 3 in 5 said that they have a document completed. Whether or not you have one, I encourage you to take action today. Go through the process for the first time or do it again. Go to a class, attend a workshop, reach out for a meeting with one of our Advanced Care Planning Partnership volunteers, and then share your experience with your patients. We all need to work together to normalize this work and help our community move forward. You are also taking action today by learning from one of Wisconsin's leaders in palliative care, including palliative care education and systems change to support effective palliative care. It is my pleasure to introduce Dr. Tim Jessick, palliative medicine physician with Aurora Healthcare in West Allis, Wisconsin. Dr. Jessick is the chair and co-founder of the Palliative Care Network of Wisconsin.
Hello, everyone. Thank you for participating today. What a great opportunity to not only talk about advanced care planning, but also what can happen with a systems approach. So the title, as you already heard for the talk today, is Palliative Care for All, One Systems Journey to Make Generalist Palliative Care a Reality. But what I want to really clarify for folks is that even though I'm talking about palliative care for all, I'm not expecting that you all will become palliative care specialists. But everyone on this phone call does do palliative care on a regular basis. You have conversations with your patients. You work with symptoms and symptom issues. So I want you to think about this presentation from that perspective. I'm also excited to share a story about our community hospital and how with communication training, with systems change, with support from a hospital and from a system, we can move the dial, we can make a difference for folks. So advanced care planning is super important from way upstream, as you heard with Ellen, but is also very important when the rubber hits the road at the very end. So we'll be discussing that more. As you heard from Ellen, I'm a palliative care doc with Advocate Aurora Health. Used to be a family practice doc. I know the last 11 years I have been doing palliative care full time. So the objectives for today is to really describe the barriers, but also the opportunities for hospital systems change to really improve what we call palliative care services for all patients. Again, not specialty palliative care, but primary palliative care. And even though I'll be talking mostly about the work at our hospital, the same approach really would apply to other facilities, other settings, so nursing facilities, clinics, and so forth. We'll be talking about some key steps in designing a new system of care, including standards, staff education, electronic medical record changes, and also QI projects that can be done. And we'll discuss some action plans. So how can you start your own generalist palliative care initiative at your setting, at your facility? So just a little bit about my facility. Aurora Healthcare is a very large health system, one of the largest in the state. At the time of this study and this work, we had 15 hospitals statewide. 13 of those hospitals actually had palliative care clinicians or a program in place. Our hospital itself is the second largest hospital within the system, about 350 beds total, but really more about 140 beds as far as med, surgical, ICU type of beds. And we've had specialty palliative care since 2010. Since the study and the work that I'm presenting today happened, we have merged. So now it's Advocate Aurora Health. So now we have 27 hospitals within Wisconsin and Illinois with multiple clinics, long-term care facilities. But what's super exciting about the merger is mergers go, is advanced care planning, shared decision-making, and serious illness has become a tier 1 project for our very large system. Our two systems and two hospitals saw the need, saw the urgency for doing very good advanced care planning upstream and having this discussion with as many folks as possible throughout the continuity of care. But also include shared decision-making, goals of care discussions for our serious illness folks. So very excited about that piece. I can discuss that more later on. So for our hospital at Aurora West Dallas Medical Center, what was our burning platform? Why did we do any of this work at all? Well, several of us, not only from a palliative care perspective, but also from hospital leadership, from clinical leadership, kept seeing these cases again and again, where we basically had system failures. And our system failures had to do with failures to communicate, failures to rescue, and failures to plan. We also kept seeing these cases where sick patients were coming to our facility, coming to our hospital, and we're doing everything for them until the very end when they said, nope, this isn't working, we should stop, and then they'd be switched to comfort care within a few hours of death. And then for some patients, it seemed like this maybe not be the care they wanted. We saw a lot of folks dying in the ICU, and we saw a lot of patients that died in our hospital that didn't even have advanced directives or designated power of attorney. So this really became our burning platform as we saw these cases again and again and again. So we had an option, or we had some opportunities at this point. We could have just done some lunch and learns. We could have done some educational processes or some lectures. But between our chief medical officer, our director for quality, and some other leaders, we really decided that we needed a new system. We really needed a top-down approach to this problem to really address the problem, so we could hardwire it and really correct the issues at really the root of some of these problems. So, really our case study, again, at West Dallas Hospital, just outside of Milwaukee, was really a 3-year project. We knew we couldn't do this in a couple of months. We knew we couldn't do this in a year. Culture change like this can take 3 to 4 years. So over 3 to 4 years, we really want to improve the care for our seriously ill patients. And we really want to reduce a lot of these failures already mentioned. Failures to communicate, failures to plan, and failures to rescue. And our hope was with this change that would improve patient satisfaction, to be more pleased with the care that they're being provided. There's more care that was concordant with their wishes. We're hoping it would help reduce our inpatient mortality rate, specifically our deaths for the patients in the ICU. We also thought, especially for our sicker patients, it might help our hospice referrals. So that was really the hope all along. So just a brief comment. You heard a little bit from Ellen about palliative care. So is palliative care the specialty beneficial? And study after study really does reaffirm this, that palliative care consultation and involvement does reduce symptom burden, so pain, nausea, constipation, anxiety, and so forth. It really does improve patient and family satisfaction. Now, is it because all palliative providers are fantastic people? Well, it's probably part of it, right? But really, the secret sauce is that we really try to meet patients and families where they are. A lot of other clinicians do the same thing, but that's really our mode of patient care. Is how can we meet this patient? How can we meet the family where they are? How can we understand their goals, their needs, and different aspects that are really important to them, and then provide care that's very similar and satisfies those needs. And that's really the reason why I think we have such great patient satisfaction. Palliative care reduces ICU stays. It also reduces mortality rate, readmission rate, especially 30-day readmissions. We know we reduce healthcare costs in general. And actually, New England Journal of Medicine article several years back did show that we do have a survival advantage, especially for stage 4 metastatic cancer. So how can we apply? Remember, I said at the onset, this is not about specialty palliative care and every hospital getting as many palliative providers as possible. You all should have palliative providers in the inpatient setting, outpatient setting, community setting, right? But palliative care can't see all these patients. We just don't have the bandwidth to do that, right? So how can we apply this patient-centered approach, this palliative approach for all patients, and how can we teach and train others around us to use that same approach? Well, the way we look at patients is that all patients should be assessed for unmet needs, pain and symptom issues, anxiety, depression, pain, spiritual screening, so forth, right? What are patients' goals? Who is their decision maker? What are their hopes and dreams down the road? So all patients should be assessed the same way. And then primary palliative care needs can be met by generalists, by primary care clinicians, specialists, hospitalists, EM docs, APCs, nurses, bedside nurses, social workers, right? Who all are doing this all the time. Most of those needs can be met by generalists if they're aware of that and if they're looking for this. And there's still going to be need for specialist services at some point, right? And we're available, palliative care is available for that, but a majority of these needs can be done by specialists or by generalists, not just by specialists. So this is what we talk about with patient-centered approach. So we really want to improve outcomes, and we did at our hospital. We wanted this systems change. We wanted a new system. In order to really improve outcomes, we had to do more than just education. And we all know the studies tell us that education by itself is probably only about 30% effective, right? But education with systems change, with support, with measurement, with accountability, putting those together, that's when you'll see the improved outcomes, and you'll see some of that data later on. So just a comment about key conversations. When you're talking about advanced care planning, so important from way upstream, 18 years of age and older, but all the way through the continuum of care. So I like to look at the conversations as 3 different categories. The category 1 is really for the healthy folks, 18, the 18 years of age and older, even some that are older than that, but they just don't have a lot of disease processes. Well, what kind of conversations do they need? Well, they need skilled, trained facilitators to help them with advanced care planning, to help designate surrogate decision makers, and to really start this process. But it needs to be a trained facilitator. But those are the type of conversations needed more upstream. Category 2 conversations are really for those folks that have chronic diseases. Now, you hope they already had some advanced care planning upstream and earlier on, right? Where they can discuss surrogate decision makers and so forth. But these are folks that might have mild to moderate asthma. They might have class 1, class 2 heart failure, maybe stage 1, stage 2 cancer, maybe slight dementia. So they have some chronic diseases going on. Not only do they need good advanced care planning, they need a little bit more in-depth conversation about their values, some early goals of care type of discussions, and in some instances, code status discussions. Do not resuscitate. Does this make sense for them or not? Category 3 conversations are really for the last year of life, last year or 2. These are folks that are nearing the end of their life. Their disease process is getting worse over time. Again, you'd hope that they had a bunch of advanced care planning discussions upstream. They filled out documents that designated surrogate decision makers. You'd hope that they've had a couple of discussions and rediscussions. Hey, Mr. Smith, it looks like you have, you've had some advanced care planning in the past. You have an advanced directive document. Is your wife Mary still your power of attorney? And if at that point the patient says, well, no, we've been divorced for a couple of years, a good system that's in place would say, well, boy, if you've been divorced, your document's null and void. Let's work on getting a new document for you. So that has to be an ongoing process. But for these sicker folks with a year of life to live or less, you really need to start having late goals of care discussions. What really matters to you? Which treatments really make sense for you based on your values and your goals? Does palliative chemotherapy really make sense or not make sense? Does extensive surgery or very aggressive surgery make sense or not? And for some folks saying, boy, I think I want to focus more on comfort if I only have a year to live or less, or 6 months to live or 3 months to live, I want to focus more on comfort. Really discussing hospice and that type of care can be very, very valuable. So different conversations, different skill sets at different times of life. Just some basic principles on the communication training we did. We initially started with docs only. We started with a small group learning environment, generally less than 20 to 25 folks. We thought learning was better this way. We used the Dr. David Weissman model in communication training and goals of care training. We made sure we had time to discuss personal attitudes. How much of what we do as clinicians are based on your personal values versus professional values. So trying to reframe that and look through that a little bit was really important. We had plenty of time to practice different words to use during role playing, and what words work, what words don't work, and focus on some of those micro skills. And then we also had didactic time where we really talked about advanced directives, advanced care planning, prognostication, ethics, and legal issues, just to get a wide variety of information for folks. This just shows you the agenda. Generally, it can be anywhere between a 5 to 7 hour course. Again, a lot of didactic work, a lot of policy explanation, a lot of questions answered, but a lion's share of the time was really spent with training folks how to have a family meeting, how to have a goals of care discussion, how to break bad news, how to deal with anger and conflict, but also some role-playing time to discuss code status. So again, the key was not only the group discussion, but really the role playing and practicing this new skill, this new communication skill was vital. So initially when we started this program in West Dallas, this was probably about 7 years ago, we decided to train our medical executive committee members first. So our chief of staff, our chief surgeon, our hospitalist leaders, our cardiology chief, right? As well as other members of the medical exec committee, just so they could see firsthand what the training was all about. What was amazing is once they went through this training, we put them in the hot seat and we had them do simulation training. When we went back to that group and said, boy, we'd like to do another training, the response was unanimous. Yes, we should do another training. Here's more money to do training. How many more are you going to do? And at what point can you train all the hospitalists, all our EM docs, all our clinicians? The response was huge. So getting buy-in from your leaders to see firsthand what this course is all about, what communication training is all about, was really helpful for us. So to date, starting at West Dallas, started it all off. Today we train over 400 hospitalists, including the majority of the hospitalists throughout our system. Our emergency medicine physicians have been trained, a lot of our specialists from oncologists to cardiology. Our chief nursing officer kind of opened my eyes as we were focusing on docs, saying, wait a minute, there's a lot of nurses, there's a lot of APCs that do a lot of this work. Shouldn't we be training them as well? And she was absolutely right. So we started training more of the APCs within the hospital and the clinics and the nursing home APCs. They do so much of this work and do it so well. We did a lot of communication training for them and the CNSs and their directors of quality. And then we started training some of our internal medicine residents and our medical students. So today we've trained over 400 folks throughout the entire Aurora system. Just basically logistics-wise, getting support from medical exec committee was key, top down and from the leaders. Having some of those leaders go through the course was really important. It was after that they said, boy, we should require this type of training for all of our hospitalists. And that was a directive from our chief medical officer. Funding was really split between the hospital administration and the medical staff. It was fantastic to see that both groups saw they needed to have skin in the game. The hospital was benefiting from docs doing and clinicians having better conversations, and the clinicians themselves were seeing this benefit. To see that contribution and awareness was hugely important for us. And then we provided CME credits for the clinicians. The other big part of this was physician follow-up. Again, communication is a skill. Folks can do it well and they can do it not so well. So especially with these type of conversations, we thought it was really important to have 2 follow-up mentoring sessions with our docs afterwards, where we'd have them go in a patient's room with us. They'd have a goals of care discussion, and we just watch. And afterwards, we debrief. How did that discussion go? What went well? What didn't go well? As a way to really reaffirm that having these discussions are important. To practice the skills, but then to get feedback from us, and that went really well. We helped them with documentation. We provided a documentation template for these discussions, and we started doing chart reviews. We looked for the presence of goals of care notes and also the quality of the goals of care notes based on the content. So just briefly, our old goals of care note, we've made a couple of revisions, had some just basic information. We wanted clinicians, again, docs, APCs, and nurses to really think about, does this patient actually have an advance directive on file? And if not, maybe I should get one. Is this patient decisional? If not, who do I need to be talking to? What is the patient's code status and the rationale for code status? And basically, what are the patient's goals of care? So just a basic example of a goals of care document that we see in some of the charts. From an advance directive perspective, the healthcare power of attorney is in an electronic medical record. Daughter Susan is the power of attorney. At this point, the patients do not resuscitate, do not intubate. The rationale for this decision is the patient really has a poor prognosis, and the family would prefer a do not resuscitate status at this time. Decisionality-wise, the patient's not decisional, and in general, this is an 85-year-old with diabetes, dementia, weight loss with new infection, possibly sepsis. The patient is very likely to die within 12 months, prognosis-wise. POA wants to try antibiotics and fluids to reverse infection. But the power of attorney does not want an ICU admission or surgery, limits to care. If patient deteriorates or does not improve within 48 hours, then the POA would consider a shift to hospice care. So very specific goals of care for this patient. So the plan is IV antibiotics for 48 hours and then reevaluation after that. So just an example of goals of care and how that can look. So what happened with some of these changes? So we looked at our cases, we saw that we had some opportunities, we did communication training. What other quality improvement initiatives came from this? Well, we looked at our last 50 deaths. We needed some data. We needed some proof that this was an issue. Our gut was telling us that we have a lot of patients dying in the ICU and not a lot of advance directives completed. But we really needed to get the numbers. So we looked at our last 50 deaths at our hospital to really look for some of these opportunities. We developed a very robust mortality review committee, and I can talk about that a little bit more later on, based on Dr. Jean Huddleston's work at Mayo. How can we look at charts and how can we look at all our charts to make care safer for the living, basically? So we started reviewing all our mortality cases. We mandated the 6-hour communication training for the medical staff and specifically for the hospitalists. We got support from the hospital and from the medical staff to mandate this training for the hospitalists. They saw this was so important to do this. So we trained the hospitalists in communication training, documenting their discussions, and we started doing chart reviews. Other quality initiatives based on some of the work and what we were seeing, well, we saw a lot of folks dying in the ICU. We also saw folks that were dying in the ICU and they were just being yanked off vents, right? So we developed a palliative ventilator weaning process for all ICU patients that are going through a terminal wean. We noticed that patients that were not getting DNR bracelets, do not resuscitate bracelets, on our oncology floor. Actually, only 30% of our do not resuscitate patients had bracelets. So we developed a quality improvement project to improve on that, to help folks with do not intubate bracelets and so forth. So really this work led to partnering with a lot of different folks, different committees, skilled nursing homes, and so forth. Just briefly about Mortality Review Committee. Again, we really did get support from hospital leadership within the committee. We had our CMO, we had our CNO, we had our Director of Risk reviewing these cases with us and attending these meetings. Palliative medicine was involved, pharmacy was involved. We did weekly evaluations of all deaths. A doc and a nurse would review every single death in our hospital, looking for those opportunities for improvement, but specifically looking for system opportunities. This is not the old morbidity mortality case review where we're trying to blame a doc for messing things up, or this nurse clearly killed this patient. We look for system opportunities. How can our system, how can our hospital, how can this floor improve care to make care safer for patients? And that really was our focus with the reviews and our committee. So what did we find? When we did the last 50 death analysis, what were some of the themes that we found? Well, sure enough, we saw a lot of patients dying in the ICU. We saw a lot of folks that were coming to the hospital, but also the ICU. Again, push, do everything, and then comfort orders were done, and the patient were ordered, and in 24 hours, the patient died. We saw a lot of hospice patients, home hospice patients that panicked. Their symptoms got really bad and they ended up going to the emergency department or became inpatients and then died in the hospital. One big trend was we saw a lot of folks that came in that did not have goals of care discussions. And if they did have them, they clearly weren't earlier on in the stay. We saw a lot of folks with sepsis. We saw a lot of folks that expired 5 to 10 days into their stay. We really thought that day 3 to 4 is kind of a critical point where that's when those goals of care discussions really could occur. And we also saw a lack of advanced care discussions and advanced care planning and advanced directives. So this really became our burning platform, really based on this information. And now we all of a sudden have this data to confirm it. So what were some of those system failures number-wise? So out of the 50 cases, 16 of the patients had a failure to rescue, 14 failure to communicate, and 17 had failure to plan. You see very clearly here how there's some crossover. Some folks had more than one failures, but this diagram really helped from a hospital, from a system perspective, say, hey, we have some failures, we have some areas to improve on. So our data. So this is the old data, but I really wanted to show you what happened once we implemented some of the systems change. So what we found out between January 2014 and June of 2015 is that really early effective goals of care discussions really can improve patient-centered care and in-hospital mortality. So what we saw was after implementing the systems change, mortality review, communication training, simulation training, and other system initiatives as mentioned earlier, we saw a decrease in inpatient deaths. We saw an increase of number and percentage of patients dying in our ICU. For those folks and our patients that did die in the hospital, specifically in the ICU, their median length of stay went from 6 days down to 3. We saw a decrease in readmissions to the hospitals, but specifically from the skilled nursing facilities. We saw a 50% decrease in code 4 calls. Do not resuscitate, or patient that stopped breathing and heart stopped. 50% decrease in code 4 calls. But at the same time, they doubled the number of calls for a stat team call. Hey, this patient isn't doing well on the floor, the blood pressure is dropping, we need staff here to transfer them to the ICU. At the same time, we saw increases in hospice referrals. We saw an increase in documentation of goals of care discussions, and we finally saw an increase in completion of advanced directives. More specifically, we saw a 7% decrease in 30-day readmissions overall for the hospital. We saw a 27% decrease in hospital deaths. 27% decrease overall. At the same time, we had an increase in the number of patients being discharged. So the fewer people in our hospital were dying in the hospital at least. So an increase of hospice referrals by 14%. Initially, for the patients that died in our hospital, only 50% of them had an advanced directive. After some communication training and some training in general, we were up to 77% of folks that died in our hospital had advanced directives. So a decrease in restraint usage and a decrease in palliative medicine consults. That part is not good for job security for us palliative docs, but it's understandable. It's kind of complicated slide, but just it really does show you that initially we were averaging about 138, 140 deaths per year. We started dropping into the 90s. Overall, and our mortality rate continued to drop over the first couple of years. If you look at our numbers over the last 3 years or so, our observed to expected mortality has just continued to drop. So fewer and fewer patients are dying in the hospital, and definitely our healthier folks are not dying at such a high rate. So when our mortality committee went to the medical exec committee and said, hey, these are our lessons learned, and these are our recommendations to the medical exec committee based on this information, based on the training, based on the mortality review. A couple recommendations. Number one is that we should be screening all hospitalized patients for unmet advanced care planning and palliative care needs. Number two is goals of care discussions really should be done and documented within the first 24 hours on the floor, especially for sicker patients, and at time of admission for ICU patients. Number three, code status discussions and documentation should be done at the time of admission. Then number four, we need more of a streamlined process to really escalate cases that need to go to ethics because of care conflicts and unclear goals of care. So we made this recommendation to the medical exec committee, and they said, yeah, I think we should be doing all these things. So this led to some of the systems change. I would like to say that every single patient that requires a goals of care discussion has one. We're not quite there, but that's the work that's the bar we've tried to set for ourselves. So all patients should have goals of care discussion at admission or soon after admission. The templates should be used, document those discussions as much as possible. We continue with our weekly mortality review and goals of care discussions, training. And then the care coordination piece is still there. We're still working with our skilled nursing facilities, collaborating with the emergency department and others. So how can you replicate this type of change, communication training, systems change wherever you are, whether it be a hospital setting, whether it be clinic, whether it be a skilled nursing facility? Well, gather data on the problem. We had lots of information to say, this is what's going on at our institution. So gather data so you can show folks that there are issues going on. Make sure you have a change committee that can look at some of these issues, but include your C-suite, include your administrators, include your hospital or clinic presidents and some of your other leadership. Make sure you have some education planning. That's really, really important, but make sure that's coupled with systems change planning. What are the standards? How are we going to document? What data do we want to gather? And what kind of quality improvement projects are needed to really make those changes? Do we need to be doing a PDSA cycle? Do we need to be using S-bars and trying to make changes from there? And I can't emphasize enough how important mortality review can be for your work. Find your partners. For us, it was the president of our hospital, our CMO, CNO, director of quality. If you're in a clinic, it might be your clinic leaders. Talk to the folks within quality. Talk to the folks within risk, right? They're very concerned about patient safety. These are patient safety issues. We do not want to be coding no-code patients. So get to know them, get some of their data that can be very helpful as you try to impact some of this change. Work with the skilled nursing facilities. If you're a hospital or if you're a clinic, having a great relationship with them is key. If we really want good continuity of care from one setting to the next, that's going to be really, really important. And then continue working with medical exec committee, medical staff leaders. Again, you do need top-down support. If you don't have support from wherever you are, it's going to be difficult to create or implement these changes. Having leadership take these communication courses, whether it be goals of care like we did, or maybe even some of the advanced care planning, first steps, next steps type training upstream so they can see what this training is all about. Again, utilizing mortality review and some of the information from mortality review can be very helpful. Start doing strategic planning early and know that you can't impact change in 2 weeks or a month or 2 months. You might see some small changes, but you're not going to be able to move the dial unless you have a good strategic plan and know that's going to take 1 year to 2 years to 3 years for real change to happen. Gather as much data as you can and make sure you have accountability. If you say best practices that patients should have advanced care planning and goals of care discussions, make sure that happens, do the chart reviews to make sure that happens on a regular basis. So really the dream scenario, and this is for our patients and their families, but we could say the same thing for our families, right? Patient-centered care really should be the norm for all patients. It should not be clinician-centered. It shouldn't be, hey, Mrs. Smith, this is what you should do because I know what's best for you. I don't know anything about you, but this is what's best for you. Patient-centered care, meeting patients and families where they are, is key. It has to be key. Goals of care should be completed and then documented for all appropriate patients in all settings. As you heard at the very beginning, advanced care planning, getting advanced directives are really, really important way upstream. That has to be done then, right? That has to be the start of the advanced care planning. That happens, across the trajectory. But for goals of care discussions specifically, for folks that are sicker, for folks that go to the ICU, they need to have goals of care discussions early and often. You might want to consider goals of care conversations as a credentialing requirement. In order to be credentialed in this hospital or this institution, you need to be having goals of care discussions at this rate. Again, you need support top down to have that happen. And ultimately, the true dream scenario is, are we providing care for patients that is concordant with their wishes? Did we rescue them when they wanted to be rescued? If they wanted to be full code, did they get the care that they wanted? If a patient's no code, did we code them? If a patient wants usual care, including antibiotics and things like that, but doesn't want to be transferred to the ICU, did somehow they get transferred? So we want to make sure that the care is concordant with their wishes to the best of our ability. So just in closing, again, advanced care planning is really, having discussions, having facilitated discussions by trained facilitator with patients early, way upstream, to start these conversations. They have patients start designating decision makers, so in case they can't make their own decision, somebody else can do that for them. But as folks get sicker and they have more complications and they have more problems, they have ongoing goals of care discussions with the patients, with their family, that would include prognosis and an idea of what might happen with their heart failure as their condition gets worse. Having those goals of care discussions ongoing by primary care, by specialists, by the EM docs, by the pan-SNF APCs, by the nursing home advanced practice clinicians, by the hospitalists, is really, really important. And it really does take a system initiative that really help this continuity-wise. So with that, I will pause for questions. Well, we all know that if someone's 18 years of age or older, they need to have basic advanced care planning, right? Those folks need a facilitated discussion to start these discussions and get documents done. Hopefully most of the folks that are watching this or listening to this know that at least in the state of Wisconsin, if you become incapacitated, can't make your own decisions because we don't have a surrogacy law, your spouse or your next of kin is not the automatic decision maker. So that's why it's imperative for everyone older than the age of 18 to have good advanced care planning upstream and get advanced directives done.
Linking your presentation to the information that Ellen shared with us about the survey, and it strikes me that much of this work probably needs to occur even further upstream in the primary care setting. Do you have suggestions or advice to those of us who'd like to see a way to integrate more primary palliative care in our ambulatory settings?
Great question. And as I think I mentioned earlier, I'm a recovering family practice doc, so I have a place in my heart for those primary care clinicians. So the first thing I would say is if we try to load more on their plates without help, they will explode. They are so busy and they're staying late as it is and being asked to do so much. But saying that, they know their patients best. They know the family units best. So if we want to do this and promote this in clinics, and I totally agree, having these discussions upstream, this is hugely, hugely important. This is where we need a systems approach. This is where we need support from a system or a clinic to say, hey, we recognize that earlier goals of care discussions are very important, and an emphasis on advanced care planning is very important. Hey, primary care clinicians, how can we get this done knowing you're all so very busy, right? We're not putting this on you. This is not in addition to all your other duties. How can we best help you out with this? Would having an advanced care planning facilitator that can start some of these discussions in the clinic be helpful, right? How do we identify patients that do need advanced care planning and goals of care? That's a systems issue. That might be an electronic medical record issue. If this patient doesn't have an advanced directive, hey, Dr. Primary Care Doc, can we refer this patient for some advanced care planning and a facilitated discussion, right? Or this patient has advanced heart failure. Hey, Dr. Jessick, the primary care clinician, this patient would really benefit from a goals of care discussion. Could we have this patient come in a half hour before their physical exam tomorrow? So we can start a conversation with the patient, then we'll come in and for 5 or 10 minutes, and then we can ask some specific questions from you. Would that work out for you? So I think the more we can help those busy clinicians, the better. So it's not just all in their laps, but we have to have accountability. We have to have an expectation from the clinic, but we also need to help them out a little bit along the way.
What did you do to have the largest impact to engage leaders to set the culture?
I go back to a couple of things. Data is just so important, because for leaders and even leader clinicians, our first instinct is to say, well, yeah, that happens at those other systems. That doesn't happen here. We have a really good hospital. We have good clinicians. We do a good job, right? And in most cases, they really do. But to be able to present data for your specific institution, hey, here are the serious safety events that happened this year, right? Or here's the data for the number of advance directives that are completed for our patients in general. Or here's some data as far as opportunities for improvement for goals of care, right? Once they see data for your specific institution and even for the system, that makes people pause a little bit, right? And especially if you can accompany the data with stories. Here's this patient that came in, they were in the hospital for 14 days. Finally, on day 13, they had a palliative consult, or they finally had a goals of care discussion. And we found out that the family never would have done any of this if they really found out that the patient really had stage 4 cancer and were going to die regardless, right? Sharing some of the stories where we could have done a better job, or the stories of, boy, this great, I got a call last night from an emergency department physician who went through this training, who said, I just saw this 60-some-year-old patient with stage 4 metastatic cancer who's here because he was doing some prep for some sort of screening test. I don't think he really understands how sick he is, and he's now 88 pounds. Could somebody call him, have a conversation with him, because I don't think he really knows what's going on. To share those good stories, where here's an emergency department doc that recognized that an early conversation was important, and then sharing those outcomes really can change the culture, and it can change the mindset of folks very quickly. And lastly, is if after you present data, here's our opportunities for improvement, and here's our own stats, and we're only at 50% for advanced directive completion for patients that die in the hospital, and it really should be much higher than that, probably 75, 80% plus, right? Once you do all that and present all that information, if folks still say, yeah, but we're probably providing pretty good care, and here's this case of this patient that didn't do very well. Well, I know that nurse, and I don't think they meant to not check blood pressure, and that's why they died, or that's why they didn't do well. To pause and say, if this was your mom, or if this was your dad, is this the type of care that we want to be providing for our family? If the answer is no, how do we change culture within this hospital? How do we improve the care? How do we provide safer care so it's good enough for our family members and should be good for our patients and their families? That can be pretty profound. We were able to improve the advanced directive completion. I think I mentioned how we went from 50% to 77%. The number has fallen since we first did the study, first looked at all this. And why did it fall? We didn't have a good system in place. We didn't have it hardwired that we look for advanced directives and have these discussions on a regular basis. So that's still an opportunity for improvement for us. To hardwire that, probably have electronic medical record alert us when a document's not done. So as great as some of those numbers looked, we didn't have the system in place to really affect change, affect outcomes consistently, because that number should be quite high on a regular basis. So just, again, it's important to have education, it's important to have these changes, but you need the systems changes, you need it embedded so that it can be hardwired. So everything that I talked about from a hospital perspective, it concerns about lack of goals of care discussions, advanced care planning, advanced directive completion, for folks getting worse. Our poor patients in nursing homes are going through the exact same thing. And the staff in the nursing homes are struggling with the same issues. And guess what happens? You know, a patient comes into the hospital, a patient gets seen in the clinic, you know, because of time factors or whatever, they don't do advanced care planning, don't have goals of care discussions, the patient gets sicker, they go to the emergency department, the emergency department doc says, yeah, you're sick, you need to be admitted to the hospital, let's meet you to the hospital sees the patient, yeah, you have heart failure and these are the problems, and you're very, very weak, and this has been going on for a while, let's discharge you to the nursing home to get stronger. Patient goes to the nursing home and with usual care, well, okay, you're here for rehab and to get some extra fluid off of you. Boy, you're breathing worse. Let's send you back to the emergency department. Continuity of care-wise, it's terrible. It's just not good continuity of care. So I think the staff and the providers at skilled nursing facilities have a huge, huge opportunity, and they see this opportunity. They value the care they provide for their patients, and now they're being held accountable for transfers back to the hospital. So they're getting dinged, they're getting penalized for sending patients back to the emergency department or if they get readmitted. So we found a really willing partner, not only in administrators from nursing homes, but also the docs, also the advanced practice clinicians that are caring for those patients. So honestly, the nurse practitioners and PAs seeing those patients in facilities, they're one of our biggest fans. They're the ones saying, hey, show us how to have these conversations. We're doing this regularly, but we haven't really been trained how to do this. Show us how to do this, show us how to document. And then what do we do if a patient needs to go back to the emergency department? Can we somehow partner with them? So it's a very logical and a very easy next step to start training folks there, but then start working on the continuity. Hey, these advanced practice nurses at the nursing homes have had this training. Hey, emergency department clinicians, if they have a patient, how best can they give you sign out? Or if they've had a goals of care discussion, they've documented the goals of care discussion in the electronic medical record, make sure you look for those discussions because it's a nice starting point. So all of a sudden, the emergency department that sees this goals of care discussion documented in the chart done by the advanced practice nurse at a nursing home can start with Mr. Smith saying, boy, it looks like you had this great goals of care discussion with staff at your facility. Clearly, you do not resuscitate, do not intubate. You seem like you have a pretty good understanding of your advanced heart failure, but you're having more shortness of breath, and that's why you're coming in. Is that right? Right? What a great transition, what a great starting point, and what a great feeling then for all clinicians involved to say, hey, we're part of a system, we have partners that are trying to do the best job possible for patients and families, and that continuity is huge. So again, communication training for all clinicians involved, documentation training, document those notes, not only advanced directives, but documentation of those goals of care discussions is hugely important for everyone to see. But then adding that system piece, what happens when a patient goes from the emergency department to the hospital, to the nursing facility, back to the emergency department? How do we best facilitate those transfers? What information is needed? And how can we best care for patients? So nursing facilities are a great opportunity for us. And as we just saw with COVID and even flu, we really need to be taking better care of our sick patients and debilitated patients that are residing at nursing facilities. When we talk about resuscitation, and the big part, at least for Aurora, is the do not resuscitate piece, right? And this is a big learning cycle for clinicians, nurses, therapists, respiratory therapists, and so forth at our institution. There was a lot of assumptions going on. So we have to start with, code status 101, which is basically what we teach in the course now, is code status 101, basic myths and so forth. We start from the very beginning. If we're all by ACLS protocol, if we assume that a code occurs when we have a pulseless, non-breathing patient, basically a dead patient, that's what we're referring to with resuscitation, where we do chest compression, shocking the heart, intubation for those folks that have died, right? That's the starting point. That's how the discussion needs to occur. That's where we have further discussions of stats and success rates. Only 15 to 17% of folks admitted to the hospital successfully are resuscitated and so forth. So the stats and the information is really, really important. One key, though, is that there's a lot of other assumptions going on. I've seen ICU nurses, docs, pulmonologists, others that assume that just because a person says, nope, if my heart stops and if I stop breathing and I die, don't bring me back from the dead. No chest compressions, no shocking, no intubation, right? Some folks then assume, oh, if this person's having breathing problems, they go from a mask to BiPAP, right? Well, they're DNR, so we'll assume that they do not want to be intubated for respiratory distress. That's a wrong assumption. There's some folks, not a lot, but there's some folks, specifically our patients with COPD or emphysema, who might say, listen, if I die from this, if I have a massive stroke or heart attack and I die, don't bring me back from the dead. But heck yeah, if I get pneumonia again, like I've had twice this year, if you need to stick a tube down my throat, rescue from my breathing while I'm still alive, and breathe for me for a couple of days, give me steroids and things so I can recover, I want that. Heck yeah, I do. So it took us months and months and months to do this education process for all staff, saying intubating for respiratory distress is different than intubating for resuscitation. So what came out of the education was an emphasis that we have to ask this question, not for everybody, but specifically ICU patients. And for those folks that clearly say, don't bring me back from the dead, and don't ever put me on a breathing machine, do not ever intubate me, we developed a do not intubate bracelet to go with that do not resuscitate bracelet. So it was a big process. We needed system input, we needed education, we needed all these changes, including a pretty old blue bracelet. But that was one of our opportunities for improvement, as we saw folks that weren't being rescued. Some folks did not get intubated when they probably would have preferred to be intubated, and we just made false assumptions. The answer is both. You know, again, I kind of have the words palliative care in here a lot, and I probably should have had a palliative care approach. The results that I just presented really had to do with teaching primary palliative care to hospitalists and other clinicians. So it had very little to do with palliative care as a specialty, right? There's only 2 of us in the entire hospital to affect change. So honestly, as we're talking to clinicians and we're talking about metrics, number one is we just need to present to clinicians that number one, we have a problem, right? In Houston, we have a problem. We're coding no-code patients. We're not really providing concordant care. We have some safety issues where we're doing things to patients that they really don't want. We have some patient satisfaction issues, right? But what we can share with clinicians and leaders and share the stats that we have is with a concerted effort to really really emphasize advanced care planning, advanced directives upstream, and then to train folks how to have goals of care discussions more downstream as folks get sicker. You do see positive outcomes. You do see a decrease in mortality if more hospitalists are having these discussions as patients are being admitted, especially if they recognize that the patients are really sick. Patients that I can identify a decision maker right up, and have that document in the chart for a patient that comes in that's delirious, having that surrogate decision maker say, well, I know my wife, she would not want aggressive care. We've had these discussions. I think going to the ICU doesn't make sense. What are our other options? So absolutely, the data that you saw really can be translated to all clinicians, all hospitals, and all sites. So, as I've been trying to emphasize, the majority of these discussions can and should be done by non-palliative specialists, right? We know that 20% of all admissions to the hospital have unmet palliative needs. But we know that palliative clinicians can only see 3 to 5% of all admissions, right? So we just can't see all the folks that need some of these discussions. So when do you really need a palliative specialist involved? Do you need a palliative specialist involved to have the initial discussion with code status? No. Do you need a palliative clinician involved to have the initial goals of care discussion and discuss basic prognosis? No, of course not. That can be done by other clinicians, primary palliative care. So when do you need a specialist and a specialist team involved? If there's conflict, either conflict within a family as far as goals and what to do, or if there's conflict within the medical team. Some members of the medical team want to push and do more, and yes, of course, we can do more procedures, and other parts of the medical team saying we shouldn't be doing this. That might be a time to have palliative involved. If a patient's having a difficult time understanding what to do, if you have a patient, you have a good goals of care discussion that's done by the hospitalist about their goals, about prognosis, and about code status. If the recommendation is, well, you should be a no code, and the patient says, nope, I want to be a full code, right? Usually the response is, well, this patient doesn't get it, or they're in denial, or something to that matter. Well, if there's concerns like that, that's where palliative care could help. Coming in with maybe a little different approach, or maybe more of a patient-centered approach, may bridge that gap. It may help with that conflict. And a lot of times what we'll find out is, yeah, the patient understands clearly that they're sick and they're dying, but they want to be a full code because their faith says they need to be. Or they feel like it's euthanasia to be no code. Or I really don't want to be resuscitated, but I have my daughter here, and if my daughter doesn't see me being a full code, they'll think I'm quitting, or whatever it is. Sometimes just asking different questions in a different way can further those discussions. So conflict, symptom management, especially symptoms that are out of control, can be very helpful, helping to coordinate care a little bit. As far as where we're going to go, what care makes sense, doesn't make sense. Those complicated issues, we're more than happy to help out. And happy to help out in the inpatient setting, happy to help out in clinics if we're available there, and ideally at some point help out in the community. As far as screening tools down the road, at the very least, there's a dozen different inclusion criteria and screening tools out there that can be used. In general, for the docs, especially that are starting out, and the APCs and other clinicians, at the very least, anybody that's admitted to the ICU needs to have a goals of care discussion. Anybody that you think might have a year to live or less needs to have a goals of care discussion. To me, that's just kind of a basic starting point. It'd be fantastic to move that more upstream. If you can, within your electronic medical record, develop an inclusion criteria that includes other diagnoses, so alert pops up for class 3, class 4 heart failure patients, moderate to severe, COPD, advanced dementia, class 3, class 4 kidney disease, right? If you can have a pop-up that identifies those folks, just like, hey, this patient's due for a colonoscopy, or they haven't had a flu shot, that would be ideal. But until that, to kind of keep it basic as far as, if they have a year to live or less, they should have it, or, leave it a little bit more wide open. Hey, if this patient has a chronic illness, that may include X, Y, and Z, consider doing a goals of care discussion. That works as well. So there's a lot of tools out there if for folks that just want to see what some of these conversations look like, and I'm sure we can include links. Vital Talk is a group that does a lot of videos on how to have these discussions, how to have a code status discussion, how to break bad news. There's videos out there you can watch at your own leisure. Respecting Choices has done some really, really good work out there, not only with advanced care planning upstream, but also next steps, shared decision making. So there's some resources there that can be a benefit. Honestly, the best way to get training for this, if you want to at some point become good at ACLS or ATLS or resuscitation and things, you can read up on it as much as you want, but to really take a course at some point and practice these skills is really, really key. And maybe that's something that we can provide in the future is a communication course like we did at West Dallas for folks in the Fox Valley or the surrounding areas to do just that. So plenty of resources out there. Again, we can include some of those resources for some basic information of how to have these discussions, but really taking a course would be also very helpful. The other piece, as far as data, as far as didactic information goes, on mypcnow.org. The website has a link to Fast Facts. So if you're looking at, kind of a step-by-step approach on how to have a goals of care discussion, you can find that there. If you're curious about some of the stats about success rate for CPR, Fast Fact number 179 has all the data you'd ever want as far as success rate, failure rate, and so forth. So that can be another resource just for some brief reading about what this means and doesn't mean.
Thank you, Dr. Jessick, for the presentation. It was very informative and helpful, and I look forward to what our community does with this information and where we go from here. So just a reminder, to earn CME credit or a certificate of participation, please read through the CE information back on the website. You need to view the entire webinar and then also complete an evaluation using the link provided on the website. This learning activity will be available for credit until July 15th, 2021. Thank you very much.